Hi folks, this is Dr. Rob CYWES. This channel is called Carb Addiction Doc channel, but today I'm going to take off that carb addiction hat and put on my surgeon's hat. As you can see, I'm in scrubs. I am a board certified pediatric and adult general surgeon, double board certified. And one of the things that I have dedicated my life toward over the last little while, maybe 23, 24 years, is to understand obesity and understand weight loss. And the two are somewhat different, okay? How are they different? Obesity is the cause of becoming fat. At least that's the way. What things are we doing? What changes have happened in our life to result in both the biochemistry, the hormonal changes, and the mental psychologic changes, the biologic and the psychologic changes that make me fat, that make me gain weight? And then weight loss is, okay, I am fat, I am carrying excess calories. Yes, I use that word, calories. How do I reduce my caloric consumption to lose weight? And we can talk about the obesity side. There's plenty on this channel. This channel is dedicated toward understanding and addressing how I became fat in the first place. But let's talk today just about strategies to lose weight. So there are three major strategies to lose weight. And I'm going to discuss them in increasing effectiveness. The first one is any form of calorie reduction, any form of intentional caloric reduction by diet, either by using prolonged periods of not eating called intermittent fasting, or adding to that intentional portion control, intentional caloric reduction. Either of those two strategies will result in weight loss. The most effective way to lose weight is to not eat at all, to go on a prolonged fast. And for some people, actually, that works. Don't think, oh, my metabolism, you don't have to metabolize what you didn't eat. But that is pretty harsh. It's pretty much out there. And most people can't do that. Certainly, you can't sustain that. But if you've got a lot of weight to lose, that's not a bad way to go. Intermittent fasting, extended fasting, or some form of caloric reduction. And just as an aside, the most effective form of caloric reduction in terms of also crossing over and treating obesity is a ketogenic diet. Today, I'm not going to talk about that. But a calorie reductive diet, either by your intent, by not eating for protracted periods of time, by not snacking, and by eating less, will result in weight loss, period. However, a lot of people struggle with that. A lot of people get despondent. A lot of people are unable to sustain that. So how do we help in the sustainability of weight loss? And really what we're talking today about is monotherapy, a single therapy to reduce caloric consumption. That's called monotherapy. The first monotherapy is diets and fasting. The second monotherapy, and this has become extremely popular in the last few years and is going to be by far the dominant, most effective form of weight loss in the world over the next decade. And that is medications. Medications. There have been a bunch of gimmicks out there. There have been a bunch of wallet biopsies and bullshit out there. For example, HCG. Well, injecting HCG in your butt never, ever got anybody to lose weight. It is the placebo effect and then the 400 to 500 calorie diet, the caloric reduction, which gets you back to the diet that really helped with HCG. But the rebound was awful. So HCG was a wallet biopsy. It was really about the diet. And it's important to understand this. That's why I'm going down this pathway. Always ask yourself, is this medication independently going to help me? Or is it because of the placebo effect, my mindset, almost a hypnotic mindset? And is it because they're putting me on a calorie-reduced diet? That's always the question you got to ask yourself. And HCG came and went because it was a calorie-reductive diet with a jab in the butt or a pill that you took to somehow magically use human growth hormone, human coronary gonadotrophin, HCG, as a way to magically lose weight. Absolute BS. Okay? B12 injections, exactly the same thing. B12 injections may suppress appetite a little bit, huge placebo effect. By correcting B12 levels, you may have a little bit less hunger for a short period of time, but that was something that was used tremendously. Then there was a class of amphetamine drugs, the fenphens, the phentamines, the Adderalls, all of the drugs that speed up metabolism, that suppress appetite, and are misused and abused by so many skinny people. They use Adderall, they use the phentamine, they use these stimulant drugs to suppress appetite. Yes, they lose weight. They lose weight, they're not eating. It's calorie reductive, but it is, and it's of value. I use them from time to time myself. I do use them from time to time myself. Not me personally, but in my practice with my patients for very short periods of time to recapture patients. And they have value, but they have enormous danger when they're used as monotherapy over time. So if you're going to use phentamine, I prefer to use it for 1 month, for 30 days to get back on track. To use it to augment the dietary changes when you've gone sideways. To use it for longer than that, it's less effective and it's got an increasing amount of harm. Same thing with the Adderalls and all of the ADHD medications that all suppress appetite. As does nicotine, as do so many other drugs out there. But their primary purpose is appetite suppression. The second class of drugs, which is really a class of drugs that I am very in favor of, are called the GLP-1 agonists. And the incretins, GLP-1, GIP, DPP-4, peptide YY, and glucagon. Glucagon is actually one of the most powerful incretins. But we don't use glucagon for appetite suppression because it drops blood sugar. Sorry, that's not true, is it? Just checking if you're listening. Glucagon actually causes a rise in blood sugar. It releases ketones and breaks sugar down. So it is not a good drug in the face of insulin resistance. But glucagon is an incretin. In fact, you want to block glucagon, not stimulate glucagon. Okay? So GLP-1 is one of the most powerful drugs out there. And it's being produced now, you know it, Ozempic, Rybelsus, Trulicity. Mounjaro is a combination of a GLP-1 and a GIP, Wegovy. They're being used in the weight loss category as well as the type 2 diabetes. They came from the diabetes production line and they've crossed over because they work in weight loss. Why? Because they treat insulin resistance. And these are very, very powerful, very healthy drugs to be on. I have no issue with them. I absolutely caution people about the high dose because high dose has a high risk of pancreatitis. And if you need a high dose of this medication, you're doing it to spite yourself rather than to help yourself. So low dose or intermediate dose is effective. It does help with weight loss. The problem with the GLP-1s, and this is not where I'm going, the problem with the GLP-1s is massive weight gain when you stop. In fact, the STEP trials, STEP trials 1, 2, 3, 4, which were done with Ozempic, all showed a massive rebound. They showed great weight loss while people were on them for 68, 76 weeks. But as soon as people stopped, the massive weight gain was enormous, just like falling off a diet. And that is because monotherapy addresses weight loss, but it does not address obesity. That's time for another discussion. But here's really where I want to go to. Still, in the modern era, and oh, you guys are going to scream at me, you're going to leave comments, and oh, it's so bad. If you are really sick, if you have tried the GLP-1s and they're not working, or they've worked and you've regained the weight, the most effective weight loss tool to make peace with is bariatric surgery and bariatric devices. And that's what I do. I use balloons, I use lap bands, I use sleeve gastrectomies, I repair gastric bypass, I repair duodenal switches, and we'll talk about that in a second. But bariatric surgery is by far the most impactful form of intentional caloric reduction. And if it is a pure surgery that creates, or a device that creates pure caloric reduction, it is very, very safe. The metabolic surgeries, the ones that interfere with the absorption of food, in my opinion, are extremely dangerous and should very, very rarely be used. They're used tremendously as a monotherapy, because they result in rapid weight loss, but 20-25% of that weight loss is lean muscle mass, which you don't want. They result in transient restoration of health because they treat insulin resistance through starvation. But long term, they are horrible operations, and I end up reversing a ton of them. I fix and I reverse bypasses, I fix and I reverse duodenal switches, and the more popular SADI, SADI operation. Those are all operations that, in my opinion, should very, very rarely be done in human beings. But of course, we look for the best bang for our buck and the easiest, simple one-stop shop. But we don't think about the consequences down the road. And my colleagues in bariatric surgery are extremely good at ignoring those consequences down the road. So bariatric surgery remains one of the most, no, not one of, the most powerful form of weight loss. And for most of my patients, the failure, including myself, the failure is being fat. The failure is having insulin resistance. The failure is being sick and fat because of our addiction to carbohydrates. We have to lose the weight and then address the addiction. And the two can happen synergistically together. So this is an appeal. If you are struggling with weight and you've tried everything, including the GLP-1s, or sometimes you want a GLP-1 together with your weight loss surgery, that combination works extremely well. We can do a less of a surgery with a GLP-1, or we can place a balloon and use a GLP-1 at the same time. That synergy gives you greater weight loss, better behavioral change. So if you're out there and you're desperate for weight loss, or you're really, really sick, your type 2 diabetes is in all kinds of trouble, you're losing your kidneys, you're losing your eyes, you've had heart attacks, don't listen to the internet that tells you, oh, you got to man up, you got to take her. Have the most effective, safe procedure to get the weight off while you do the work. Don't be afraid. Be afraid of being fat. Be afraid of type 2 diabetes. How many patients have I not seen year after year after year that I've got to lose this weight. I must lose this weight. I've got to get rid of my diabetes. I'm going to try really hard. And they are unable to sustain the behavioral changes without help. Well, the surgery is that tool that helps you to do well. Please do not demonize the surgery. There's so many people out there, oh, surgery's so bad, surgery's. Yes, it is when it's done by the wrong people who don't understand obesity management. But don't deprive yourself of the benefits of surgery, the benefits of a balloon. And if you've had surgery, if you've had a balloon and it's failed, it didn't fail typically because of the operation. It failed because nobody talked to you about obesity, about carbohydrate addiction, and about how to treat your obesity. You can't outsource that. But you absolutely can outsource your weight loss. Don't be afraid. Make peace with it. Have that procedure. Because being fat is the enemy. Being insulin resistant is the enemy. And if this is a tool you can use to help you, do it. Don't outsource it to that exclusively. Don't use bariatric surgery as monotherapy. But then don't use a GLP or a diet as monotherapy. All those people on the internet are advocating for a ketogenic diet as a monotherapy to lose weight. It's as much bullshit as anybody saying bariatric surgery is no good. They're just monotherapies. Monotherapy doesn't work. Gets rid of the weight, but it doesn't treat the obesity. But if we engage and we use multimodal therapy, we use the GLP-1, we use the obesity surgery, we use the diet, and we use addiction methodology, that's the best way to help you to lose the weight and keep it off and change as a human being. That's our investment. And this is an appeal to people all over the world or anywhere in this country. You don't just have to be in my local environment. Look to surgery as the most powerful asset for you. And yes, I do that surgery in conjunction with the obesity management. But don't let anybody out there, there's a word for it, I can't remember what the word is, but don't let anybody tell you that a ketogenic diet as monotherapy is healthy, but surgery is not healthy. Monotherapy may work for a little while, but 98% of ketogenic diets fail. 85% of surgeries fail for the same reason, and close to 100% of GLP-1s fail when you come off them. Because there are monotherapies. Multimodal therapy is your best chance of being successful for the rest of your life. Make that investment. Make that investment if monotherapy has failed you or you are struggling. Leave comments because I know you're going to blast me for this, and that's okay. That's okay. But if you're skinny, you don't need surgery. If you're not, and you've tried everything and are struggling, consider it. Oh, I'm never going to consider it. I'm not going to have... Okay. Then consider the ramifications of remaining in a state of insulin resistance and remaining obese or remaining diabetic. That's the alternative. That is the alternative. You're either healthy and you don't need surgery, or on your way to being healthy and you don't need surgery, or you are insulin resistant, fat diabetic, and putting yourself at risk of early death because you don't want to have surgery. Is the surgery a guarantee? No, but it's an incredibly powerful tool to help you. And if you failed all the other tools, why not have this? Because to me, in my own life, the failure is insulin resistance and obesity, and a mindset associated with addiction. I am the carb addiction doc. I know this is controversial. I want it to be, but it's actually not controversial. What's controversial are all those people out there saying, don't do this. Don't do this. That's what's controversial. They're preventing you from being healthy and successful. I am the carb addiction doc. Leave comments. If you like what I've said, hit the like button. If you hate what I've said, hit the thumbs down button. But put it in the context of who you are.